Thank you for joining iMeet. This meeting is now being recorded.
Good evening, everybody. This is Dr. Russell Miller from the Naval Medical Center in San Diego, and along with my co-moderator, Dr. David Shaw from UCLA Harborview, we're very excited to have you here for the first AABIP Webinar Journal Club. Today, we'll be discussing the randomized trial of pleural fluid drainage frequency in patients with malignant pleural effusions, otherwise known as the ASAP trial, which was recently published in the Blue Journal. We are very pleased to have a truly remarkable panel here today. The presenters will be Dr. Javier Diaz-Mendoza and Dr. R. Christensen from Henry Ford in Detroit. And our expert panel will include the primary author of the study, Dr. Momin Wahidi from Duke, as well as Dr. David Ost from MD Anderson Cancer Center. Some quick housekeeping issues. This will be recorded and available for AABIP members to view at a future time. Please mute your telephones to minimize background noise, which can occur. During the session, you can enter questions for the panel using the chat box in the lower left corner, and the questions will be addressed at an appropriate time. And the projector screen icon in the bottom left will toggle between shared slides and videos. And finally, the AABIP does not endorse any specific technologies or products, and the contents of this presentation represent the opinions of the speakers. So without further ado, I'd like to turn over to Dr. Christensen. Christian.
Okay, so Ara, you have the floor.
Great. Thank you, Dr. Miller and Dr. Shaw for the introduction. And on behalf of Dr. Diaz, I want to reiterate how happy we are to be invited to present the inaugural AABIP Journal Club. We do think it's going to be an invaluable educational addition to the already successful webinar series. I wanted to send out another note of appreciation to our expert panel today, Drs. Wahidi and Dr. Ost, and actually Dr. Feller-Kottman was also to join us, but he had a last-minute emergency. But all three were extremely accommodating in accepting our invitations, and so I appreciate having them here. And it goes without saying their input's going to add a lot to our talk today. So as already mentioned, we're going to talk about the ASAP trial, or its longer name, the randomized trial of pleural fluid drainage frequency in patients with malignant pleural effusions by Dr. Wahidi and colleagues, published in the Blue Journal in April of this year. So an outline for the hour. The first 20 minutes or so, I'm going to give a brief topical background overview and then present the article itself. And then we'll kind of move into the meat of the discussion through a directed panel discussion utilizing some predetermined questions and talking points. And then we'll leave the last 10 or 15 minutes or so for audience questions. I'll remind the audience that you can write your questions down in the lower left-hand corner chat box throughout the hour, and then through the webinar, we'll sort through the questions, and then the last 10-15 minutes or so, we'll direct them to the appropriate panelist. Okay, so a brief overview of indwelling pleural catheters, or IPCs, as I'll refer to them from here on out. I think we all know that they've emerged as a safe and efficient option for managing malignant pleural effusions. They minimize hospitalization. They have a low infection rate and otherwise a favorable safety profile. May indeed be cost-effective, especially for patients with limited survival. And perhaps most importantly, it seems they have a comparable palliation outcome to other more established alternatives, such as chemical pleurodesis. Now, speaking of pleurodesis, of course, this is the main thrust and focus of the ASAP trial. And I'm sure the audience already knows, but it bears repeating that pleurodesis is variably defined in the literature. Now, most commonly, it's described as the obliteration of the pleural space leading to lack of fluid reaccumulation and or resolution of symptoms But we can see quite a bit of variation from study to study on this definition, and that may affect how we interpret the results. Now, pathophysiologically, we know that there's mesothelial injury that sets off this cascade of inflammation and coagulation, ultimately culminating in fibrosis. So, as seen here, normal pleura to fibrotic pleura, effectively bridging the visceral and parietal layers and obliterating the pleural space. Sclerosants have been most commonly studied, talc, tetracycline, etc. But we know that now with the accumulating IPC evidence that simply the presence of the IPC, just having it in the pleural space, can lead to variably to pleurodesis at a variable rate and a variable period of time. So how might this occur? Well, we know that mechanical pleurodesis induces the rise in fibroblast growth factors, perhaps to levels even higher when compared to chemical pleurodesis, for example, in this study in 2015. We know that TGF-beta is a central mediator in promoting pleural fibrosis by activating fibroblasts into myofibroblasts, which then lay down extracellular matrix and result in fibrosis and so on. We know that TGF-beta is actually a pleurodesis agent. For example, as shown here in this rat model, where installation of TGF-beta already as early as day 4 is causing some fibrosis, extending out all the way to 9 weeks. And this has been shown in a sheep model as well, for example, in Dr. Light's lab. What about in humans? So a small but telling study by the Hopkins group a few years ago demonstrated a rise in pleural fluid TGF-beta levels after IPC placement. So putting all this together supports the notion that indeed what we may have here with the IPC in place is a recurrent mild pleural abrasion. Now, whether that's occurring because the catheter is directly interacting with the pleura, or we're getting a repeated mechanical stimulation from the recurrent cycles of pleural apposition and deapposition that we see with repeated drainage cycles, or a combination thereof, we do know that there's this mesothelial injury that's occurring, triggering the cascade that ultimately is leading to the fibrosis and pleurodesis. So how often does autopleurodesis occur? So a systematic review by Van Meter in 2011 showed a combined autopleurodesis rate of 46% among 12 of the studies that reported on this endpoint. Now you'll notice here that the range across these studies for autopleurodesis was very wide, 12% from the minimum all the way up to a maximum of 76%. Now this can, of course, at least in part, be explained by the fact that we have yet to settle on a consistent way of designing and analyzing this particular endpoint. So, for example, looking at this selected summary of studies assessing IPC-related autopleurodesis, we see the two randomized control trials that actually were comparing IPC to chemical pleurodesis actually had a fairly similar autopleurodesis rate, about 50%. Now we compare that to the two larger studies here, both of which were retrospective in design and demonstrated a more discordant result. And of course this highlights the importance of how we're designing and looking at the data in impacting the results that we're finding. Now I included the Tremblay study here because I thought it was unique in that they evaluated a subgroup of their IPC population that they called fit for chemical pleurodesis, or namely patients who had evidence of good expandable lung after pleural fluid drainage. And in their report, they found an autopleurodesis rate of 70%, which is on the high end of the range we have available in the literature, again underscoring the importance of how we're defining our patient population in determining what outcomes we're going to see or what results we're going to see. And then finally, what about the actual definition of autopleurodesis. What definition or what criteria are being used in these studies? Now, the audience probably already knows that the definitions tend to be fairly uniform, but if you read the fine print and you go look at all the studies and you look at the design and the materials and methods, you see subtle differences between them that ultimately can help explain why we're seeing a wide range of autopleurodesis rates in the literature. So why do we care about autopleurodesis? Well, in the vast majority of cases, this leads to IPC removal, and of course, patients are happy. They don't have to deal with a catheter. We avoid complications associated with the catheter, infection, and so on. And then potentially, there's a theoretical cost savings here, whether it's through savings on supplies, nursing care, and so forth. So this brings us to the thrust, to the primary objective of the ASAP trial and why it was done. Essentially what the authors wanted to do is compare an aggressive daily pleural fluid drainage strategy to what's considered the more standard every other day strategy in achieving autopleurodesis. And the authors hypothesized that the more aggressive strategy would lead to a higher rate and a faster time to autopleurodesis. The study was prospective and randomized, and it listed 12 centers across the United States over about a 4-year period of time. They enrolled adults with recurrent symptomatic malignant pleural effusions that were either cytology proven or tissue biopsy proven, so histology proven. Now, in the cases where we had a patient with cancer who had a pleural effusion that did not have evidence of cancer by cytology or histology, then another identifiable cause could not be present to explain the pleural effusion. So it was a high suspicion that this was a malignant pleural effusion, or termed paramalignant pleural effusion. Now, patients had to have had symptomatic improvement after their index thoracentesis, and then worsened again with reaccumulation of the pleural effusion, which of course would then justify the placement of the IPC. The study had some key exclusionary criteria, so they excluded patients who had a short life expectancy, less than 30 days by Karnofsky score, less than 30. They excluded patients with evidence of trapped lung for obvious reasons, and they excluded patients who had had a previous pleurodesis attempt. And then some other obvious exclusionary criteria: non-malignant pleural effusions, usual contraindications to performing the procedure, etc. They enrolled via block randomization and allocated equally between the two groups. Now, the patient, the study coordinator, or the treating physician were not blinded to the group allocation, although the treating physician did manage the patient independently, wasn't part of the study. The study utilized the Pleurex catheter. I think most of us are familiar with the Pleurex catheter drainage system. And again, advised the patients, the subjects, to drain either every day or every other day based on the arm into which they were randomized. The family members were thoroughly educated on the management of the catheter, and whoever was responsible for drainage was advised to drain up to a maximum of 1 liter per drainage cycle, and to keep a diary record of fluid volume and other characteristics. Okay, so the primary outcome was the incidence of autopleurodesis over 12 weeks following IPC placement. And essentially, 3 things could have happened to these patients during the study period. They could have autopleurodesed, they could have died, or they could have dropped out of the study for whatever reason. Now, if none of these things happened over the 12-week period of time, so the patients made it through alive without dropping out and hadn't autopleurodesed, then they were termed non-responders, were censored at 12 weeks, and effectively the study was closed as far as they were concerned. Now, how do the authors define autopleurodesis? So decreased drainage, less than 50 cc's per cycle for 3 cycles in a row. The patients had to be asymptomatic. And then the authors further stratified autopleurodesis by how much residual pleural fluid was left by chest X-ray. And they used a chest X-ray score of 0 to 5, so 0 representing no pleural effusion, no residual pleural effusion, and 5 representing a very large pleural effusion, for example, seen here with near complete left hemithorax pacification. Now, if the patients had a chest X-ray score of 0 or 1, 1 being a very small pleural effusion represented by blunting of the claustrophrenic angle here, in combination with no drainage and an asymptomatic patient, these subjects were deemed complete responders or having achieved complete autopleurodesis. Whereas if they had chest X-ray scores of 2 to 5, again in combination with no drainage and asymptomatic status, they were deemed or classified as having partial response or achieved partial autopleurodesis. Now, to try to tease out bias, the authors employed two separate chest X-ray reviewers, the treating physician as well as an independent blinded pulmonologist. And actually, when they studied or analyzed the agreement between the two, they found a very high concordance in their interpretation of the chest X-rays. Now, we've all been confronted with the scenario of one of our IPC patients who comes in with decreased catheter output but has a persistent pleural effusion. So what would be a chest X-ray score of 2 to 5 in the study. And of course, the differential here is that either we've achieved autopleurodesis, if that's part of the definition, or we have a malfunctioning catheter. And the authors employed a straightforward algorithm to deal with the situation. So they went ahead and, in this scenario, instilled 30 cc's of saline into the pleural space, and if this restored flow, then we had a malfunctioning catheter, and the subject was advised to resume their drainage schedule. If flow was not restored with the 30 cc's of saline, then the pleural space was treated with 2 milligrams of alteplase for 30 minutes, and then the algorithm repeated. So flow is restored, this is a malfunctioning catheter, resume drainage schedule. If the flow was not restored, then this patient was deemed to have achieved autopleurodesis. This would be a partial response. Remember, we're dealing with a patient with a persistent pleural effusion on chest X-ray. And in this case, the catheter was then removed. Secondary outcomes that the authors evaluated: time to autopleurodesis, adverse events, performance status by Karnofsky scale, quality of life by the Rand-Moss SF-36 survey, patient and caregiver satisfaction surveys, and the chest X-ray score agreement between the two reviewers that I already touched on. I'm not going to go too much into the statistics because we're going to touch on this some more in the panel discussion, but briefly the authors settled on a sample size of 75 patients per group by targeting what they deemed to be a clinically relevant autopleurodesis difference of 25% between the two groups, and this would give us an 85% power. They analyzed the primary outcome, which again was the difference in proportion of subjects achieving autopleurodesis by the chi-square statistic. Okay, so the results. We had 162 patients enrolled and randomized, 13 of which failed screening for various reasons, leaving us with 149 subjects that were analyzed and distributed equally amongst the two arms. Baseline patient characteristics. I won't go into the details here in the interest of time, but bottom line, very similar between the two groups. Also similar between the two arms was the profile of underlying malignancy in these patients, both the histologic subtypes of lung cancer as well as histologic types of non-lung malignancy. Also similar between the two arms was pleural fluid characteristics, which is very important to know since fluid characteristics often dictate how the pleural space is going to behave. And then also similar between the two groups was what treatments that these patients may have undergone leading up to the point of the study. Okay, so the primary outcome, again, was the incidence of autopleurodesis. So this is table 2, which is essentially the meat of the results here. And what the authors found was that 47% of the patients, the subjects in the aggressive daily drainage arm achieved autopleurodesis, as opposed to a much lower 24% in the standard arm. Now, one of the results that stood out to me on this table, at least, was a high proportion of patients that either died or were unable to complete the study before the 12-week period was up. And if we actually break this down, we see that this proportion is particularly poignant in the standard group, in which 63% of patients either died or dropped out of the study before the 12-week period. And we'll talk a little bit about the potential significance of this in the panel discussion. The authors went ahead and listed the various reasons for patient dropout, both patient factors and catheter or disease-related factors. And you see here various numbers, kind of a smattering of different frequencies here, but when added up, again, seem to be more common in the standard group. This is a cumulative incidence plot, or a 1 minus Kaplan-Meier plot, a curve of the two arms, detailing the probability of autopleurodesis and time to autopleurodesis based on the study arm. So red being the aggressive arm, blue being the standard arm. And of course, what you'll note here is both a vertical as well as a horizontal gap between the two curves, signifying the difference, a significant difference in autopleurodesis rate as well as time to autopleurodesis. And this was analyzed by the log rank test and found to be statistically significant. Moving on to table 4 was our Karnofsky performance status. We see that baseline performance status was similar between the two groups and remained relatively equal between the two groups at 12 weeks. But you'll note that the performance status improved in both groups, and this is what we would expect and hope for with IPC therapy. This is the quality of life table results, table 5. I won't go through the details in the interest of time, but suffice it to say that all the subcategories of quality of life were similar between the two groups, and this was true at each evaluation point, pre-insertion, 2-week, and 12-week. Similar also between the two groups were adverse events, detailed here in table 6. The authors found a little over a third of patients had pain with drainages, and found an extremely low infection rate, again in keeping with pre-existing data. And then finally, patient satisfaction. I didn't go through I didn't list here all of the tables, but you can find these online in the appendix. But a few of what I thought were the more relevant questions. The patients were asked about their dyspnea level as compared to before a catheter insertion, and you can see here in both groups, subjects responded that their dyspnea significantly improved. Also, similarly in both groups, subjects noted that the catheter was very easy to manage and drain. And then finally, when asked if they had the option, if they would choose to have the pleural catheter again as a treatment for their cancer-associated dyspnea, a very high percentage in both groups answered in the affirmative. So the authors concluded that a more aggressive drainage schedule led to a higher rate and faster time to autopleurodesis. The authors noted that both approaches had acceptable frequency of adverse events and that both approaches had very good patient satisfaction. So the strengths of the study, I think, are fairly obvious. The authors asked a very important clinical question. It was a prospective randomized multi-center study, and it was potentially very applicable to clinical practice, especially to us as interventional pulmonologists. So at this point, I'm going to turn the microphone over to my faculty mentor, Dr. Diaz, who's going to lead the next portion of the webinar, which is going to be our expert panel discussion.
Hello. Yes.
Hi, Dr. So we've passed the control over to you, and if you need us to advance the slides, just let us know.
Okay, I think I'm going to need you to advance the slides. I cannot have control here. It doesn't accept. Okay. First of all, thank you, Ara, for such a great presentation. And thank you to our expert panel of today, Dr. Wahidi and Dr. Ost. Just to remind you both about the times for answering questions. Each panelist will have 5 minutes to answer the questions that were given, and there will be some additional time for replies if needed. Please, to the audience, type your questions in the chat icon that you will see at the left bottom corner of your screen. We will address those questions at the end of the discussion. We'll have 10 minutes for that. So, in terms of the first question, this is a slide that Ara already presented earlier. This is a graphic that reminds us of the possible events that happened during the study. And just to divide it in the groups that Ara already mentioned, we have the autopleuresis group that could have been either complete or partial. We have the group also that had no response. And we have a third group that we will call censor, that we will put in there patients who died before the 12 weeks of the completion of the study or were unable to complete the study for other factors. Next slide, please. So in this trial, what we saw was there was a large proportion of censor patients that were actually censored, I would say, before the 12-week period, either by death or dropout. There was also a significant difference, as you can see on the table 2, between the two groups. The aggressive arm presented 37% of those patients actually were censored in the study versus 63% of those patients in the standard arm. So next slide, please. The first question goes to Dr. Wahidi. You may use 5 minutes to answer the question. Any thoughts on the reason for this difference?
Yes, so thank you, Ara and Javier, for this excellent presentation, and thank you for the opportunity to discuss our research. So this question obviously is an important one, and it really was an important discussion point for us, the investigators on the study. We could not find a reason for this difference. First, let me talk about mortality. I think we discovered during the trial that we clinicians are horrible about predicting mortality, despite the fact that we did not want to enroll patients who might die soon because we wanted them to survive for 12 weeks. All the investigators shared the sentiment that we are not very good at predicting the mortality for these patients. I mean, as you know, the median survival for patients with malignant pleural effusion is about 4 months. But it was a very common scenario. You would see somebody with metastatic cancer that they looked good, their Karnofsky score was above 30, but yet they died before the end of the study. So the other thing is the inability to complete the study. And again, we could not detect a real reason why. You saw that table. That was our attempt to look at every patient's reason why they couldn't finish the study. Some of it was patients' wishes, some of it families' wishes, some of it non-compliance, which actually went both ways. Some of them in the standard arm wanted, drained daily or more frequently. Some in the aggressive arm drained less frequently than daily. So there's compliance issue, there's patients factors. I think that, again, this is a randomized clinical trial. You hope to eliminate bias. I don't think the investigators had anything to do with this higher sort of dropout death in the standard arm. We could not detect a specific reason. And I don't think that the patients were biased, if you will, meaning that did the patient drop out because they did worse in the standard arm. And actually, you would think that the intervention arm would be that way. If you have a new intervention, patients might do worse and they withdraw. But it was the standard arm, what we do every day, where there was more dropout and more death. So again, no explanation. I mean, you can go on with theories. This is how the results came out, and despite the best intention of the investigators and the hope of eliminating bias by doing a randomized control trial.
Okay, so moment. Let's go to the next slide, please. Do you think that these events could have been associated or with or could have impacted the observed autopoiesis rates?
Again, it's hard to speculate. I have no way of telling, again, whether that difference in the dropout affected the results or not. I'm not a statistician. We've had a lot of discussions about this. I'd love to hear Dr. Ost's input because he's somebody who has an MPH and has a lot of experience in this. But again, our repeated discussions and analyses is, could the results been different? Obviously, in a randomized trial, anything's possible. But again, I cannot say with certainty whether the results will be different if the dropouts or mortality rates were different between the two arms.
I see. Thank you very much. So can we go up one? Actually, this is the table that you were referring to, Moment, in terms of the different reasons, correct?
Yes.
So let's go one more slide, please. So the next part of the question is for Dr. David Ost. David, do you think that this large proportion of patients that were actually censored and this difference between the two groups, do you think that this should change our approach to analyzing the outcome, and how would this affect our conclusions, if at all?
Well, thanks very much, and thank you for inviting me to participate. This is an excellent study. I think it's well done and very much needed in the interventional pulmonary field. So the long and the short answer, if you can go to the next slide, is dropout is always a consideration, and even in the best study, people will drop out, die, unexpected things happen. The concept we want to understand is that randomization is an attempt to control, the key word being attempt. It's not a guarantee at controlling for observed and known confounders, as well as those which are unknown. But you can always get unlucky, okay? Now, in the analysis, the primary analysis is a logistic regression analysis. And you have in front of you on your computer screen the Kaplan-Meier. Just a quick point, a very subtle but important one. The cumulative incidence function is not the same as 1 minus the Kaplan-Meier curve, okay? The cumulative incidence function is really what's needed from a competing risk model. I'll try to briefly touch on that and why it matters to us as clinicians in a little bit. But going back to the logistic regression, just look on the horizontal line, go out to 84 days and draw a vertical line up. What you're doing is, that's the difference that you're doing in a logistic regression. It ignores all the information to the left of that line. You know, so the curves could be enormously different, and yet they come together at 84. And we choose 12 weeks as relatively arbitrary. Imagine you had picked, now Moment used excellent judgment, he picked 84 days, but if he had picked 9 or 12 months, everyone or many more people would have been dead. And the number would have looked, the curves would be much closer, and you might conclude incorrectly that there was no difference between the populations, right? At the other extreme, what if you had picked it at 10 days? You would say there's no difference. So it's sort of arbitrary when we pick 12 weeks or the other way. I like this analysis, which is the secondary analysis, because it deals with the problem of dropout. So the dead people are correctly labeled as censored events, okay? There's nothing you can do, and that's just the way it goes. And in the Kaplan-Meier, we deal with censoring that way. For those of you who are interested in clinical trials, the key thing about censoring, there are many assumptions which are necessary, but the teaching pearl here is for the Kaplan-Meier model to work, and the Cox model, censoring has to be uninformative, meaning you are just as likely to get pleurodesis or not. But so I think the conclusion is pretty robust from this study. I'm sure other trials may get different results, but the secondary analysis really helps. The other aspect, though, that I would emphasize, and maybe the author, Lomi, can comment, or the other authors, is when we say pleurodesis, that was a very elegant presentation by Ara, and what we mean by that is this fibrosis and closing of the pleural space. But notice, when you pull the catheter, there is no guarantee that you really have pleurodesis. All you have is a drop in fluid. It could be that your chemotherapy is working and you're producing less, and it may be that you wait another month and the fluid comes back. So we really don't have proof of pleurodesis, but as physicians, I would say this is still a meaningful outcome. It's pulling the pleural catheter and having no symptoms of dyspnea, right? That's what we really care about. But if you're going to do the studies, you then want to track the patients and say, I pulled the catheter on this patient on day 60. If I declare victory, but on day 70, after I pulled the catheter, it comes back, that's not victory, right? So we have to be careful. And just something to keep in mind when you design the studies, you look at the data, and you look forward. So in summary, good study. Secondary analysis really helps. Be cognizant of what censoring is, and the cumulative, to get back to the cumulative incidence, remember in the Kaplan-Meier, all the dead people are not counted, okay? And that's a biggie, because that, if you said, and your patient says, Doc, what's the percentage chance at 12 weeks that I'm going to get this catheter out, okay? The chance is not 60% if you drain it every day. Remember, there's a 1 in 4 chance, or whatever the mortality was, that they're going to be dead. And that doesn't show up. What this says is, of those who are alive at that given moment, because you counted all the other people who died. So the cumulative incidence function is different than 1 minus the Kaplan-Meier.
Thank you very much, David. We appreciate that. Momen, would you like to say any comments about this first question that we just addressed?
No, I mean, I think, again, David covered it very well. I really have no other comments. I do agree that there's a variety of other outcomes that we could have looked at or future studies can look at. You can argue that, dyspnea by itself should be the outcome, not autopleurodesis, or the need for re-intervention, meaning you take the catheter out and then, as David mentioned, the following 3 to 6 months, what happens? Do patients need more intervention? So these are all, good points for future studies. Obviously, we went with what we thought was the best outcome when we designed the study, but there's a lot of other really good outcomes for future research.
Okay, thank you very much. Could we go to question number 2? Thank you. So question number 2, the autopleurodesis rate in the standard arm in the ASAP trial was actually lower compared to other rates reported in previous studies. As you can see in this slide that was already presented, the standard arm had a 24% of autopleurodesis compared to a spontaneous pleurodesis shown in previous systematic review, which was approximately 45%. So next slide, please. So, Momen, any thoughts on the reason for this finding?
Sure, I'll give my opinion, and then I'll ask David to comment. So I think, the data is the data. This is what the study showed. And prior to this, I believe there's only, out of all the studies that ARA showed, there were only 2 that were randomized controlled trial. Everything else was retrospective. So, the accuracy of the data is always in question when it's retrospective. I think the other thing is, remember that in our study, we sort of stopped the study at 12 weeks. And this was, again, our estimation of the time, reasonable time for pleurodesis, a meaningful outcome in our mind. After 12 weeks, it may or may not be meaningful. So other studies did not stop following patient at 12 weeks. A lot of these studies did follow patients all the way until they died, or even months to a year or two. So it is possible that if we continue the study for 24 weeks, the autofluorescein rate might have approached that of the previous literature.
I see. And well, the next part of the question is, how would this affect our interpretation, application of the study, if at all? But you already sort of answered to that also. So, David, do you have any comments about this question?
Is that me, David, or a different?
Yeah,
David?
David Oss. I'm sorry.
Sorry.
David Oss. There are so many Davids.
I agree with Momin's points. I think the numbers, and if you look at the meta-analysis, whenever you read a meta-analysis, it's important not to just look at what we call the point estimate, because what that meta-analysis really shows is heterogeneity. The numbers are wide-ranging, so you cannot just take the average or the weighted average and say that's the true number. Heterogeneity of studies tells you a lot, and part of it, Momin's right on target, it's the definition. I would encourage people or invite people to think about what he said. If we had waited longer, some would eventually get the catheter out. So imagine you do the Kaplan-Meier and you just extend it to the right. Eventually it's going to plateau, but we don't know when. And there are other studies done after the meta-analysis which show that. And, in our experience, it starts to plateau at about 5 or 6 months, meaning, notice the Kaplan-Meier methodology. Given that you are alive, if you have gone 6 months, you are much less likely to get your catheter removed than given that you are alive at 3 months. Your rate of success is lower. So I agree with everything Momin said there in terms of the difference in rate. To me, it's right on, it's not that unexpected, so it's not a big deal.
Thank you very much, David. So now we'll go to question number 3, the final one. So this study has raised important questions about the cost and care-efficient management of malignant effusions. So this question is for both of you, Momin Wahidi and David Ost. What should the interventional pulmonology community study next, and what do you think are some related investigations on the future that may impact the management of these kind of patients with malignant pleural effusions? We'll go first with Dr. Wahidi.
Well, I think there's a lot of potential exciting studies in this area. I think if you look at the tunneled pleural catheter versus fluorodesis, we still don't have a lot of good data. We have probably one study that compared tunneled pleural catheter with fluorodesis, chemical fluorodesis, I should say. I think there's an opportunity to understand that more. A lot of the guidelines in pleural disease suggest that tunneled catheter should be first line only in trapped lung, not in expandable lung. I think, defining that aspect of tunneled catheter is important. There's, as you know, ongoing study about a tunneled catheter that's coated with silver nitrate to see if chemical fluorodesis can be combined with tunneled catheter. I think the idea of the combination is very intriguing. There's trials being set up for putting actually talc or other chemicals through the tunneled catheters. So I think these are all great studies that hopefully will be done, and I think we'll all learn more about it. The tunneled catheter is now one of the standard of care options, and we need to understand it better and really understand where it fits in the management of malignant pleural effusion.
Thank you very much, Momin. So David Ost, any comments about this question?
I do think the idea of comparing alternative strategies is a good way to go. I think the guidelines, in our practice at MD Anderson, pleural catheters really are the mainstay. And it's just important to think systematically, right? When we say thoracoscopy versus pleural catheters, a lot of patients aren't eligible for thoracoscopy. You know, they're too sick or whatever. So a randomized trial of those who are eligible for both really could be informative. I think the outcomes are really, to be honest, very similar with pleural catheters, and you don't have to stay as an inpatient. There are some upsides, but it's definitely worth looking at. I would say the other thing, as a society, as a community of interventional pulmonologists and pulmonologists, is, you know, this is something that pulmonary medicine does well. It requires longitudinal follow-up. But the majority of thoracenteses and pleural catheters, I think, done out there are actually done by radiologists. And it's just something, you know, you really want to think about in your own practice. This is from SEER Medicare data. It's unpublished. We hope to publish it. And that's only a trivial side note of the study. But in some ways, it says, okay, if you want to deliver quality care, it's about longitudinal care. It's about choosing the right strategy. And who better than us to do that, you know? And it's just something to consider.
Well, thank you very much, David. We appreciate the comments and the answer. Thank you very much, Moment, also. Now we're going to go to the audience questions. And I haven't seen anybody who has actually typed a question in the box. So
the panelists were too clear.
Yeah. So I'm just, is there anybody in the audience who would like to ask Drs. Moment Wahidi or Dr. David Oz here about the study?
While we're waiting, I have a question. This is Ara here, and this is for either Dr. Wahidi or Dr. Oz. So one of the, I guess, we have some accumulating evidence that tumor burden seems to inversely correlate with chance of pleurodesis. Namely, there's less mesothelium available to be injured, and hence our fibroblast growth factor load doesn't get as high, and we don't get pleurodesis. Do you think, looking at the discordant results with death and disease progression in the two arms, with the standard arm being a little higher, do you think that may have indicated an underlying higher tumor burden and potentially driven down the autopleurodesis rate in the standard arm?
I guess I'll start. I'm not sure we can tell whether there's a higher tumor burden in either group. I mean, you saw the baseline characteristics. They're actually amazingly, this is a power randomized trial, amazingly similar. I mean, I was really pleasantly surprised about the distribution of cancer and the demographics of the patients. So I think it could be a hypothesis. Obviously, this theory of higher tumor burden leads to less pleurodesis has been sort of discussed, whether that mainly for chemical pleurodesis, but does it apply to the tunneled catheter? Perhaps. I think it's a good question to consider in the future. We did not I don't think in the table we stressed, we did not mention all the information about the cancer, but most of the information.
Great, thank you.
Well, we have actually a question here from one of the persons in the audience. So do you think that this study supports daily drainage in all patients with tunnel catheters for malignant effusions?
I'll take a crack at that and then let David comment. I would say no. I think this should inform the clinician and the patient about the data, and they can then decide based on patient's preference, desired outcome, social support, available resources. I think this informs the process to customize the approach. In a patient who is just happy to have dyspnea and they don't care if the catheter ever comes out and maybe have short survival, even draining the catheter once a week or twice a week is totally fine as long as they're breathing fine. For patients who want the catheter out, but their lives are better if the catheter is out and they're looking forward to sort of get as close as possible to a normal life and removing the catheter, I think daily drainage, based on the current data, might get them there faster, might get them free of the catheter faster, and get them free of potentially fluid, pleural fluid, and relieve their dyspnea faster. So that's my take on it.
I think Moment's approach is very reasonable. This is David. In general, one relatively small randomized study doesn't close the books. Otherwise, we'd be all racing to give insulin in the intensive care unit, and we would have closed the door, turned off our thinking, and we'd still be giving Zygris to everyone. And so our history is replete with single studies which did or didn't, or subsequently proven maybe not to be definitive. But it doesn't mean that the study is not informative. It informs our decision. I start with a prior probability in my mind that daily is better, and then I get data from a study, a well-designed one like this, and I revise that probability, in this case upwards, in favor of once a day, but it's not a probability of one that it's better, right? It's not a certainty. It's just one small study amongst an ocean of data, but it's still a very good one. So it's informative, but you're never going to have a single study which is definitive. Well, maybe like the lung health study, but that's going to be rare. But it's still very useful. I think very practical study, and I would encourage people to really consider it. There was a nice point, a little tidbit of data in there, but you have to read it carefully on dyspnea. Moment's point about the patient's preference for dyspnea. At 2 weeks, the reported difference in improvement in dyspnea is greater in the aggressive arm, which kind of makes sense, right? On one level you might say, if I drain it every day, on a daily basis, I have less dyspnea because I have less fluid. Another equally reasonable opinion would be, yeah, but in that one day you don't get that much and won't make that much difference. Having said that, looking in the online supplement, the instrument used for that isn't a validated one. So it's really tough to say. But it might be that the quality of life is subtly different, and I really like Moment's approach. Ask the patient, hey, you can do it both ways. What do you feel? And there's nothing wrong in real life, because when they start off, they've never done it. They don't know. And you can say, okay, find out. Which way do you like it better? Doing it every day makes sense early on. And if you find you really hate doing it, then you can become a slacker like me and do it every other day.
Okay, thank you. There is another question here. Do you think that this data and the differences in death dropout will permit cost modeling of drainage every day versus every other day?
Except for Moment, I think.
Yeah.
Well, so I think this is a question we get asked a lot. What about the cost?
Right.
What if draining every day is a lot more costly, obviously, than every other day because of the cost of the bottles? And we don't know. It could be that draining every day cost, might be offset by earlier freedom from the catheter. We don't know, and we don't know that answer. I think we need a cost-effectiveness analysis. We didn't do it. We're thinking about taking this data and put it through a cost-effectiveness analysis. It will be a model, obviously. And I'll let David comment on the value of doing sort of a modeling like that and how would it sort of influence real-life decisions.
Yeah, so certainly you can build models, and models can be very useful. In this case, of course, the model is only as good as the data you put in, but models really, I think can be super useful, and this is a good use of them. But let's be careful what models do and do not tell us. Models are tools of the mind, just like our bronchoscopes are tools for our hands in doing procedures. They allow us to systematically think about complex problems and the ways different variables interact on the outcomes that are of interest to us. One outcome is time to catheter removal. Another is patient happiness. If you're happy one way, how much money is that really worth? I may not be able to answer it in the model, but at least I can make the trades more transparent. If I do X, I'm going to have to pay this, but my payoff will be Y. That I get it out sooner. Maybe 2 weeks earlier. Is 2 weeks worth that difference? Well, only the payer can decide that. But so modeling is useful. Where I think it goes wrong is that people start to believe their models are reality. It's not written in stone. They are just tools which help you think hard about problems. That type of model, that decision analysis, Monte Carlo simulation, and the sensitivity analysis is as important as the point estimate of the effect. Meaning, what if my cost was this? How much would it be different? Because the cost might differ over what range of options, and how does patient preference impact that? And that can be a pretty complicated model, but this is not a bad situation to do it, because a lot of those questions are not easily answerable, and there's so many between patient differences that the answer, the quote, right answer, unquote, will vary based on patient preferences. Our goal is to inform the patients to the best of our ability so that given their patient preferences, a optimal strategy can be chosen. We don't guarantee outcomes. All we can say is we took the best shot in the most calculated manner to achieve them in a manner consistent with the patient's preferences. So I do like the idea. I like Momin's answer, and we just want to be cautious about what models do and do not tell us.
So I have a question about that for Momin and for David Ost. Since you did the study, and I know that David, you practice this at MD Anderson, do you ever encounter issues with insurance companies when you try to go to the daily drainage in this patient?
I can answer. We have not seen that. As far as whether you on the form you check daily or every other day, we have not seen that. Whether that would be an area of scrutiny for the payers in the future, we don't know. But as far as I know, we have never been challenged about daily drainage.
Okay. What about you? No.
No, it's the same here for us at MD Anderson. If there are problems, I'm not aware of them.
Okay. Now there's a question actually about what are the feelings about rigid versus flexible thoracoscopy, and if the decision about doing any of those is based on science or just preference. I'd like to try to answer this question first and see. Well, in our case, what we do is we combine both of them. Flexible as well as semi-rigid and rigid thoracoscopy at the same time. We feel that the biopsies that we take with with rigid thoracoscopy are actually much bigger when it comes to that. But I don't think there is any science really behind it. Obviously, the IP community seems to do more of the semi-rigid thoracoscopy, but I don't know what your feelings are Moment in terms of this. Yeah,
I think I would say they're pretty much equal. I do have to say I do semi-rigid, and sometimes getting an adequate biopsy is challenging, but people are being creative. with that, using various instruments, and even some are experimenting with cryoprobe to get larger pieces from the pleura. So I think they're equal in efficacy. There's one area in the literature that stands out a little bit, which is mesothelioma. Certainly in semi-rigid, because of the size of the biopsy, when you look at comparative studies, the accuracy, the diagnostic accuracy rate is a little lower with semi-rigid. But other than that, they're pretty comparable.
Okay. Any comments on that, David? Austin?
No, I don't really do thoracoscopy anymore. I think the literature for other than mesothelioma is, as Momin said, it's not definitive. But I mean, in good, technically competent hands, I'm sure the outcomes are not that different. So 6 of one, half dozen of another. And I like your approach. You can do either. So adapt to the individual patient.
Right.
So Javier, I'm going to interject here. We're going to run out of recording time, so I'm going to stop the recording. But as long as our panelists are available, we can continue.